back to NT PG channel. So in this video, it is a second video on acute heart failure. In this video, we'll talk about the classification of acute decompensated heart failure. The first video, we just talk about the introduction. So here we'll look into classification. So acute decompensated heart failure is classified into mild to moderate acute decompensated heart failure, so which happens in 70% of patients. Then there is hypertensive acute decompensated heart failure, and it happens in 15% of patients. And the third classification is acute pulmonary edema in 10% of patients. And then there is cardiogenic shock, which correspond to 5%. So this is a classification of acute decompensated heart failure. So let's look into each of this type. So first one is mild to moderate acute decompensated heart failure. So as I said, it occurs in 75%, and this 75% of patients will have an underlying heart failure with a mild congestive symptoms. It's just mild congestive symptoms. There will be no pulmonary edema, no cardiogenic shock, and no hypertensive crisis in this patient. So basically, the patient is having some fluid overload. So it can be like pleural effusion, edema, ascites, jugular venous pressure. So management of this type of heart failure is by the prompt treatment of the causative factor which is causing this mild congestive symptoms, and also with diuretics we can manage this condition. We have to adjust the dose of those diuretics and give to the patient. So in this type of condition there is no emergency care required. The second classification of acute decompensated heart failure is hypertensive ADHF. So here the patient is having an underlying hypertension with either heart failure. Maybe the patient is not even having heart failure, just underlying hypertension with left ventricular hypertrophy. So usually the patient comes because he missed taking the drugs, so he's having this hypertensive crisis, like his BP will be more than 180 bar 120. So in this patient also it's just an hypertensive crisis. There is no pulmonary edema and no cardiogenic shock, and the patient will be having mild pulmonary congestion. So management of this patient is to provide the adequate BP control by giving the hypertensive drugs. And the third classification is ADHF with acute pulmonary edema. So it is the first two was like not so severe, and in this third type it is the patient is coming with pulmonary edema, and it is a severe condition and we cannot miss this diagnosis because the patient will be in a very severe state, and the patient will be having suffocation, air hunger, and very extremely diaphoretic. He cannot even lie down, and he will be in upright position. So the patient will come in stretcher. If we ask the patient to lie down, he will not. He will again sit up, and also we can diagnose this patient. And it is very rare to miss this diagnosis of pulmonary edema. So the patient will be having tachycardia, elevated blood pressure, tachypnea, extreme distress, dyspnea. And the investigation in this situation, first of all, we will have to go for ECG and the cardiac markers, troponin, and also in pulmonary edema can be firstly because of cardiac issue, and also secondly because of renal issues can also cause acute pulmonary edema. So in this case we'll have to check the serum creatinine and blood urea as well in order to rule out any renal issues, and it is very important to rule out any renal issues of acute pulmonary edema. Maybe the patient just need dialysis, and if he doesn't think of renal issues, we can completely miss this course. Then also it can in acute pulmonary edema can happen in situations like acute AR and acute MR, aortic regurgitation and mitral regurgitation. So it is very important to do an echo in the situation. So in on auscultation, will get fine crepitations in this condition in acute pulmonary edema. So this was the third classification, and let's look into the fourth, ADHF with cardiogenic shock, which happens in 5% of patients. So here the patient is in cardiogenic shock, genic shock. So it means the systolic blood pressure is less than 90 millimeter mercury, and also with signs of reduced end organ perfusion. So there is narrow pulse pressure, there is pulses alternance. The patient is fatigued with altered mentation, cool extremities, pre-renal failure. So the causes of cardiogenic genic shock in ADHF can be mostly acute coronary syndrome and also acute AR and MR, and the third cause is cardiac tamponade. So investigation is like the same in acute pulmonary edema, ECG and echo to rule out the causes. So here it's a picture demonstrating like left heart failure. The patient comes with dyspnea, orthopnea, and there is no elevation of venous pressure, and it has like acute severe pulmonary congestion due to left ventricular systolic or diastolic dysfunction. So as we see in this patient, he's having edema in his foot, and he's upright. So these are like the patient looks like. So these were the classification, four classification. Now let me talk about NT Pro BNP. So brain natriuretic peptide and NT Pro BNP in patients with intermediate probability of heart failure. So it is like a diagnostic marker. We can check the NT Pro BNP levels, because it is highly sensitive. It means like if a patient is having more than 900 picogram ml of NT Pro BNP levels, it means there is 90% sensitivity and 85% specificity for acute decompensated heart failure. So we basically check these levels when we are in confused, like we are not sure that the patient is in acute decompensated heart failure. Then there comes the rule of NT-pro BNP. By checking its level, if it is more than 900, we have got this 90% sensitivity to for acute heart failure. But we have to know that know this, like an obese patient, there is false negative chances and false positive value in renal failure patients. So differential diagnosis of acute decompensated heart failure can be pneumonia, can be reactive airway disease, and pulmonary embolism. So so I've completed the classification. I have talked a little bit about the NT-pro BNP use, and now the first two classification I have talked the management, then and third, like it's just simple. In hypertensive crisis, we go for adequate BP control, and even in the first case, there is no any requirement of emergency care. But in acute pulmonary edema and the cardiogenic shock, as I said, it's a complicated and severe situation. So the management, let's look into the first of all, let's look into the management of acute pulmonary edema. So for this patient, after the diagnosis, or once we know the patient is in this situation, we first of all we have to give the non-rebreather face mask with high flow oxygen and make the patient sit in 45-degree position. Then the first thing what we have to go do is IV diuretics for the pulmonary edema, and it's not like just 30 or 60 milligrams of diuretics works. It's not like we have to go for 360 milligram of IV furosemide IV diuretics dosage. So it's given like 100 like 100 bolus 100 bolus 100, so total of 360 milligram of IV furosemide is required. And if IV laxatives is not available, we can also or in a wetter situation, 100 milligram of torsemide in 50 ml normal saline over 30 minutes is used if furosemide is unavailable. And after giving this IV diuretics, we have to monitor the BP continuously, like give one bolus, measure the BP, keep the monitor aside to the patient and measure the BP so that the BP don't fall down so much. And also nitroglycerin is used as a vasodilator, so 5 microgram per minute, and increase this dose of nitroglycerin to up to 25 microgram per minute. And there is no role for any other vasodilator in this situation. And in some cases, some doctors also use IV morphine 4 milligram, and it is used in order to shift the fluid from intravascular to the extravascular compartment. But it's used, like not all used, but it has got a minor role in this condition. And once if it does all this management and still there is no improvement to the patient of acute pulmonary edema, then we will have to shift the patient to hemodialysis room and start scuff, which is called slow continuous ultrafiltration. It is basically like hemodialysis, we have the diffusion and ultrafiltration. So here in scuff, basically the solutes are not diffused, but only the water content solution has been filtrated. So we use the scuff, and thereby the patient gets improved. And also in case of acute AR and MR on echo, if we found out the cause of acute pulmonary edema is due to an acute AR or MR, then we need an urgent afterload reduction. For that, we use IV nitroprusside. And there is no role of any other drugs other than this. Like there is no role for nisretide and all, which is used in AR or MR. In order to reduce our afterload, we use IV nitroprusside. So that is a management for the patient with acute decompensated heart failure with acute pulmonary edema. So basically the main thing is IV diuretics 360 milligram. Then we can go for vasodilator nitroglycerin. And the fourth one, the management of cardiogenic shock patients. So now the patient is in shock, the systolic BP is less. So in this patient, the management is through intra-aortic balloon pump or ECMO, which is extracorporeal membrane oxygenation. Basically, we don't we give diuretics. It's not that already the patient's BP is less, we don't give diuretic. It is not like that. We give diuretics for this patient as well, but vasodilators are avoided in this patient. So now in underlying heart failure with reduced ejection fraction, so there is also heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So the management in heart failure with reduced ejection fraction is inotropes, and here the patients already, because of the sympathetic activation and all, it's already vasoconstriction taking place, so we give a vasodilator. So the drug of choice is milrinone, which is phosphodiesterase 3 inhibitor, which has got inotropic and vasodilator action. Or if it is not, or if milrinone, or then the second choice can be dopamine. If both are unavailable, for it's like milrinone is not available, and in order to use dopamine, we need a systolic blood pressure of like more than 100, then we go for dopamine. And heart failure with preserved ejection fraction, so the ejection fraction is preserved, so we have to give the vasoconstrictors like vasopressin and noradrenaline. So that's all about the acute heart failure. So I have completed acute heart failure in 2 parts. I've tried to include all the important points and give an overview and overall understanding of acute heart failure. Thank you for watching the video. Please like, share and subscribe, and let me know the comments in the comment section. Thank you.